Good afternoon and welcome to this session on acute heart failure. My name is José Barrabés. I work at the Hospital Vall-d'Hebron in Barcelona. I'm chairing this session with Héctor Bueno from the 12 de Octubre Hospital in Madrid. I transmit the apologies of Dr. Bosch, who is in the program and that for a health problem could not come to this meeting. You know that acute heart failure is a very important problem for all of us who treat patients in the acute setting, and the scientific information regarding the appropriate identification and stratification and management of these patients is probably much worse than that we have for acute coronary syndrome patients, and we have the opportunity to discuss these issues with two experts on this field that Héctor is going to present right now.
So I think we have two very different speakers that will actually focus the topic from two different sides. One of the narrow focus, very close to the acute phase in patients, and Harlan from let's say, more wider system view of the problem. The first one, Veli-Pekka Harjola, he's medical director of the emergency department on the Helsinki University Central Hospital. He is a real expert in acute heart failure and cardiogenic shock. He's actually the chair of the acute heart failure of the Heart Failure Society, and it's really experienced in the field. So he's going to, I hope, enlighten us something of this challenging need of something that works really for medical therapy in acute heart failure. So he's going to focus on clinical trials in acute heart failure and targeting interventions to achieve optimal phenotypic subpopulation. So Veli-Pekka, please.
Yes, thank you, Mr. Chairman, and ladies and gentlemen. It's a real privilege to be here in your nice city here and this excellent conference. As you can see, I have a very challenging title of my topic, but what I'm going to tell you is about the challenges in phenotyping the patients, in doing recommendations, finding the evidence base behind the recommendations, and doing current and future trials. So actually, you are all well aware that the acute heart failure is very malignant syndrome. It's fastest growing over the acute settings in many emergency departments and leading cause of hospital admissions. So it's a very costly disease. People stay in the hospital in Europe and many other countries for 1 week, but in the US maybe much shorter time. The mortality in these patients is high, and I will show you that after acute phase it becomes higher than in the chronic patients. And actually the difficulty behind this is that it's a wide spectrum of syndromes. It's not a single disease like, for example, acute coronary syndromes and ST elevation MI. One of the challenges is that these patients are elderly and they really have several concomitant diseases. They are having cardiovascular diseases, like the whole list of here. They have pulmonary diseases which make similar symptoms like acute heart failure itself. They have diabetes, which worsens the risk. They have maybe had cerebrovascular accidents and many more things behind. So it was very interesting that the ESC launched this Euro observational research program and looked at the heart failure patients all over Europe, and I showed just shortly the one-year follow-up results. The patients here, I think they are a bit younger than in many other registries, and that of course depends from which countries the main population comes. If we would go to Spain, I think the mean age would be maybe even higher, but anyhow, patients over 75 years of age are, they construct almost half of everyone. Females, around 40%, the patients with relatively low blood pressures, 1/4, and the mean ejection fraction is just in the limit of preserved and a low ejection, reduced ejection fraction. The patients who have chronic heart failure but who do not have previous hospitalization built up in this population, 30%, and 40% have had a previous hospitalization. But new onset patients without any history of previous heart failure build up 30%. And typically in all the current randomized trials, these new onset patients are excluded. So the studies concentrate on the chronic heart failure patients. Many of these patients had relatively long history of heart failure, high proportion of ischemic heart disease, and here the proportions of COPD and cerebrovascular diseases, and more importantly, renal dysfunction are high. We all know that renal dysfunction is a really high prognostic marker in whatever disease in all over the medical field, so not only in heart failure. And these curves here, which actually go up to 1,000 days, but if you look at the one year all-cause mortality, here in black are the patients who were hospitalized, and then those patients who were outpatients. They were not included in the table I showed you before. So the 1 year mortality is this much higher in those patients who are hospitalized in comparison to the stable chronic patients. So we should do everything to avoid the acute hospitalizations. Again, while you get to hospital for acute heart failure, then you have a high risk of getting a new hospitalization, which is around 1/5 during a 1 year period. Well, the initial approach to management, of course, starts from treating the life-threatening conditions and stabilizing the patient, and at the same time establishing the diagnosis. We should look what is the patient profile, the clinical profile of the patient, and then start initial therapies, which are about the same in many of these scenarios, but not in all. And I will go through them a bit more in detail. And of course, there is some kind of cause or precipitant behind. It could be acute coronary syndrome, it could be rapid atrial fibrillation, it could be an infection. So we need also to aim our therapies to those factors. And then we have this kind of symptomatic therapies, which is very important in order to, for example, to discharge the patient from hospital, that the patient is not severely symptomatic. And when we go through the patient data, these are the Euro Heart Failure Survey 2 registry and Alarm HF, which was a combination all over the international combination all over the world. You can see that acutely decompensated heart failure patients, which are the congestive patients, the mildest form, I would say. So they build up around 50% of the patients if we look at these two. Then pulmonary edema is a bit smaller in the European patients, clearly smaller in these international populations, one third. And the rest of these, which of course are very, very important things, but you have right heart failure, hypertensive heart failure, high output heart failure, so they still make much smaller proportions. And cardiogenic shock, which is the most severe form, which has very high mortality, it's around 4%, I would say. So this is very common picture about the clinical profiles of acute heart failure, whether the patient has congestion or not, or whether the tissue perfusion is adequate or low. And then you have the combinations warm and dry, which would be the stable patient without congestion. Then you have the warm and wet patients, who are the rather easy congestive patients, which you can treat easily with IV vasodilators, maybe with diuretics. And in some cases, if there is pulmonary edema, you can benefit from CPAP therapy or other non-invasive ventilation. This is the most severe patient population, and if we think this cold and wet, so they are the cardiogenic shock patients, in which you then need the inotropic support. And I think we must do everything we can to find out the patients with cardiogenic shock early enough, because every hour worsens the prognosis. We get from, for example, the arterial blood gas analysis or venous blood samples, lactate levels, which is a very clear sign of cardiogenic shock or whatever hypoperfusion. So if lactate is elevated about 2 millimoles per liter, and after that, the higher it becomes, the higher the risk. And then you have the clinical signs: mental disturbance or confusion, oliguria, cold, sweaty peripheral circulation. So those things you can find out clinically, and you should focus on treating these patients especially. And then you can also think about the pathophysiological mechanism. So whether there is this kind of cardiac reason, more gradual onset, fluid accumulation which causes gain in body weight, the blood pressures may be normal or low. Patients mostly have fatigue, some dyspnea, and in contrast to this part, where the fluid is distributed to the lungs, there is not much fluid accumulation, but it's in the wrong place, and there is thus no weight gain, and everything occurs very rapidly. So this is kind of the hypertensive pulmonary edema patient, and this is also one way to differentiate these patients. Patients with right heart failure are, again, a very different patient population. This has several etiologies, but you can find interesting data from our working group's collaboration with, for example, Stavros Konstantinides, who will be one of the speakers today, about the role of right ventricle and how to treat it. In cardiogenic shock, it's not only about heart itself, but rather early it seems that there becomes a clear inflammatory process. So this inflammation makes the things even more complicated. So you should stabilize the patient before he enters to this spiral of inflammation and worsening of coronary perfusion, ischemia, and again ischemia, and then at last death. In acute heart failure, I think these are the levels of recommendation, the classes of recommendation and levels of evidence in the current heart failure guidelines from 2012. And you can see that the highest level of recommendation is in loop diuretics, and then the nitrates have a rather high level of evidence and recommendation. Morphine, again, rather high class of recommendation, but low level of evidence, and here you see the inotropes having different levels of or classes of recommendation. So as such, we do not have any 1A level of recommendation in the current guidelines, which of course is a bit alarming thing. And here is just to remind you about these classes. So mostly class 2A, 2B, which means these should be considered, may be considered, and the level of evidence B or C, or so single randomized trials or just a consensus. The current ESC guidelines for example, in acute pulmonary edema or severe congestion recommends to start with loop diuretics, maybe give oxygen, which we of course do if the saturation is low, maybe give opiates, and then categorize or make a strategy regarding the systolic blood pressures. If you have elevated or let's say normal or elevated blood pressures, you can give vasodilators. If low, you need to add inotropes. And you can see that in this this heart failure registry, inotropes were mostly given to those with low blood pressures. But interestingly enough, they were already also given to those with normal blood pressures. Nitrates were given in a very low percentage, and diuretics to every patient group. We know from registries that in this propensity score matched population, inotropes increase mortality, and you can see also that vasodilators seem to improve mortality. And these clinical trials from which we get our recommendations, for example, the dose-HF study, which was published 2011, so there was no significant difference in symptom relief or change in creatinine when the patients received furosemide in boluses every 12 hours or as continuous infusion. I think this is an important message because infusions are given in some hospitals rather often, but maybe giving 2 boluses a day is very much easier. There was a trend towards better symptom relief if you gave 2.5 times the oral dose which a patient had been having at home versus a low dose which was equal to the previous oral dose. And there was no significant change in creatinine, which was good as such. But this was only a trend and not a significant difference. And what about nitrates? The evidence comes from 20 years ago. And this is a kind of a landmark study in that field. Gad Cotter studied boluses of isosorbate dinitrate in hypertensive, they were really hypertensive pulmonary edema patient, giving 3 milligrams every 5 minutes after having been given furosemide bolus. And in contrast, the other patient groups received high-dose furosemide every 15 minutes and a rather low-dose isosorbate nitrate infusion, but it was doubled every 10 minutes. And what was the conclusion in this rather small study? Less patients required mechanical ventilation in this high-dose isosorbate nitrite bolus group. Less myocardial infarction and less adverse events in that group. One way of decreasing elevated blood pressures is to give calcium channel blockers. Here is a Pronto study in which they gave clevidibin, but the primary endpoint was just the difference in symptoms. So there have been several drugs and trials which have not given us significant results. The primary endpoints have been mortality or combined endpoint of mortality and heart failure hospitalization. In some of these trials, there has been even negative outcomes, but in most of these there has been symptom relief, but no change in outcomes. And that is, of course, makes us think whether they were wrong drugs, wrong concepts, or wrong study design. Importantly enough, many of these have been also placebo-controlled. Some of them have had active comparators, which of course makes difference with the outcomes. Here are the recent studies which will be, I think, published, most of these this year. Interestingly, RELAX-2, TRUE-HF, and this BLAST study. There, I looked from the NCT database, also interesting study with high-dose spironolactone. So why have these trials failed in acute heart failure? I think because this is so complex syndrome and anyhow has high morbidity and mortality. but the current recommendations are not very much evidence-based. The therapies, they improve dyspnea but have no effect on CV mortality. And still there are only few therapies under investigation. Thank you.
Thank you very much. We will leave the questions for the end of the whole session, and we will handle both talk together. So the second speaker is Krumholz. He's professor of medicine at Yale. You know him well. He's director of the Center of Outcomes Research Evaluation and professor of the Institute for Social and Policy Studies. He's got several papers published, nearly 150 on the heart failure. So he started as a for more clinical view, and he's now very much studied on the, let's say, system perspective on the impact of heart failure and the management of heart failure and the outcomes in the recent years. So I think this question, whether these clinical needs in this, I would say, desperate need to improve the care in acute heart failure actually is calling for a change in the system. So do we have only a clinical problem? Do we have a system problem? Do we have both? So I hope you can...
So many questions.
Exactly.
I have a question. How many people here are using Twitter? Anyone? So you know that there's a hashtag Simposio CI. I think if you have questions, you can put it through Twitter. We can also look at Twitter to see. But I always judge my talk. If no one tweets anything from my talk, then that's a pretty good message. You didn't think I said one thing that was interesting. So I'm going to check to see if you think anything I say is worthy of Twitter. Oh, okay. Alex. You can tweet. He's asking whether Twitter is useful. That proves that maybe there's something. Oh yeah, at HMK Yale, if you want me to see it. So, the interesting thing about cardiovascular disease in this era is that we are living through a period of dramatic change. Right before our eyes, we're seeing the diseases change. For the older cardiologists in the group, I don't see any here, but if we had any older cardiologists in the group, they would remember in their training a very different spectrum of disease, a much narrower spectrum than what we're seeing today. And just take acute myocardial infarction, a very different course of care than we're seeing today. Many more arrhythmias, much more cardiogenic shock, a very different use of the coronary care units. And we're living through a period where things are extraordinarily in dynamic flux. Now, as I started on this talk, by the way, I noticed that there's a lot of evidence also in Spain of the importance of heart failure, this particular topic of this talk. I like this study from a few years ago, from the Price study, that was saying actually the prevalence of heart failure in Spain may reach 6 or 7% as a prevalence, which is quite interesting because your prevalence of ischemic heart disease is lower than many other countries. But I was interested to see that heart failure itself is still quite common. And as I went through the literature, I found many, and this is just, I just put up a couple, many good articles on heart failure focusing on the experience in Spain. We have also had quite an interest in this area, as Hector suggested, including the paper that he led that was published in JAMA that was a very nice examination of this dynamic change in this condition over time. And we've followed this study up as we've sort of carefully tried to understand what's going on with this study by Jerzy Chen, and then more recently this study that we have in circulation, which is trying to understand what exactly is happening with the conditions in front of us. And this study from 1999 to 2011 took advantage of our large Medicare database, the only national database in the United States that captures for a segment of the population all of their healthcare utilizations. And I show this to say, over that period of time, we had almost 6 million hospitalizations for heart failure. Of course, MI and stroke are important conditions for us to study and prevent, but it shows and emphasizes how heart failure is the dominant condition. For the last 20 years, the #1 cause of hospitalization in the United States has been heart failure. And so it makes it worthy, not just because of the suffering it causes, but also because of the burden on the system overall. And it makes the case for the system to invest more in the prevention of these conditions, of these hospitalizations. Now, here's the very interesting thing that's gone on during this time. It's been consistent across conditions, but in absolute numbers, heart failure has been the major beneficiary. Look at the difference in hospitalizations per 100,000 people from 1999 to 2011. One of our problems, by the way, in the US is it takes time to accumulate the data. We do not have real-time data. For most of our reliance on a database like Medicare, we have to wait 18 months or 2 years before we get the data to begin to work on it. It's a problem we're trying to fix, but we're at a great disadvantage. We're always talking a bit more about history than we are about contemporary experience. It's a problem in research and in policy. But look, in this period, the dramatic decline per 100,000 in heart failure admissions. We see it also in MI and stroke. But here, in absolute numbers, it's profound. It's a profound change. Now, we also, at this same period, we're observing a decline in mortality. In this case, we're looking at 30-day mortality from patients hospitalized with heart failure. Now, this is at a time, by the way, when there is also an emphasis in the United States to reduce hospitalizations overall. So I think most people would reflect and say, you must be sicker today to be hospitalized in the United States than maybe a decade ago, or certainly more than 2 decades ago. When you got to 1999, sometimes we would have what were called social admissions. Someone was there, maybe the family or didn't feel comfortable taking them home, or the person lived alone. We would often just bring them in the hospital. It would be for their benefit, but their condition didn't merit it necessarily. That has changed dramatically as the criteria for admission has increased. And so I say this to put this in perspective. Of course, MI, we would admit then, we would admit now. There are no MI patients that would not be admitted to the hospital. But for heart failure, it's often a discretionary decision. Does this person need to be in high-level observation, or can they be managed at home? It can vary. The decision may vary from place to place, from doctor to doctor. The decision isn't an automatic decision. But even in this period, what we see is this is 16% decline in the 30-day mortality over this period of patients hospitalized with heart failure. It compares with this remarkable almost 30% decline in AMI mortality, and stroke mortality also declines. But as we look at heart failure itself, and as we still remain frustrated by the high mortality rates and the large number of people who are being admitted, looking over the last horizon of the last 2 decades, we're seeing a change in this population and a change in the frequency of the hospitalization. And in fact, at least in short-term mortality, there's evidence of gain. Now I will tell you, as we look out 1 year and 3 years, this benefit is seen to be less, but still we see some progress. Now this is interesting when we looked at the United States in this article. What this is showing is the variation in the rate of heart failure hospitalization in different regions of the country. In the US, we have this band where the socioeconomic status is much lower than the rest of the country. And the number of minority individuals, African Americans in particular, are much higher in this area. We consistently see that this is the area of the country that has worse health care. You can almost always draw an oval like this, and here we see it again. But if you use the same standards in 1999 and in 2011, you see that almost all areas of the country now are as good as the best areas were in 1999 with regard to their hospitalization rates. Now, if you recalibrate the map to 2011. You change the legend and now divide this into 20 different regions. You see that this area is still higher, but it much lower. The other map is showing you much lower than it was, but when you recalibrate the map, that's where you see that we still have a problem in this area. It still is inequitable. It's just that it's better than it was. So it was interesting in the last talk, this issue about outpatient. Everything I've shown you now is about hospitalization for heart failure and the progress we've made. Outpatient heart failure I find excruciatingly difficult to understand and to study. How do we identify these people? The Framingham criteria are antiquated. There's little that's really known about this group, in particular because what is the time, we say time zero. What's the beginning part to start following them? Because when you say the inception of the disease, well, some people may have been walking around with the disease for quite a long time before someone diagnoses it. How do we begin to say this is the starting point to study? How do we understand the prognosis? How do we make the clear diagnosis? And then there's another question. Who actually needs to be hospitalized for heart failure? We can all agree on the extremes, but there's a middle ground where there's been very little study about the marginal benefit of hospitalization. Does this person really need to be in the hospital? Do they need to be in the coronary care unit? To what degree do they need observation, or can they be sent home? Or can they be observed for 6 hours in the emergency department during a diuresis and then even brought back the following day? We've spent far too little time. We have no standards. There's variability in the application of judgment around this very important decision about who needs to get into the hospital. Now, there's a question that arose among our group as we were studying this issue as to, is it true that these patients are getting more complex? In clinical practice, we all feel that the patients we see today are much different. In fact, so many of them are like complex geriatric patients who happen to have heart failure as one of many conditions that they have. This is a very different frame than when we went through training and we get a lecture on heart failure. We're taught about heart failure. The chapter in the textbook just talks about heart failure. When we're tested, we're just asked about heart failure. That's not like the patients we're seeing today, who are patients with multimorbidity, polypharmacy, and are juggling many different problems at once. We see a very narrow spectrum of the pure AHD. We see many more patients who have a constellations of problems, but we wanted to study this. In the administrative claims data, the billing data, there's many more codes for comorbidities. But we asked the question, well, maybe people are just adding codes. Does this represent really more comorbidity? In the United States, we have a national survey where people are actually taken in and examined, tested, and we make inferences. It's called the NHANES study. And we took the NHANES study and we looked for trends in comorbidity, disability, and polypharmacy and heart failure. These represent people who are carefully studied individually, not in the hospital, but people living in the community, to try to understand who are these people. Here's what we found. Patients with heart failure have grown substantially more complex over the last 2 decades. In this nationally representative community dwelling sample, the proportion that was very old increased twofold. So there's been a shift in the age of patients with heart failure as life expectancy has increased. Several comorbid conditions, hypercholesterolemia, diabetes, obesity, kidney disease, thyroid disease, and osteoporosis were significantly more prevalent. And the mean prescription drug use increased by 50%. So this is a representative group in the United States. When we're seeing them now, they're having much more comorbidity. The drug use has increased by 50%, and there are many more people 80 and older. This is common sense to most doctors, but this is definite proof of what's going on. And we're just showing the number of comorbid conditions across is increasing. So I don't have to go here. So there's also another change that's occurring that's right aside this, which is the use of devices. and in particular the use of LVADs. In the United States, the use of LVADs as destination therapies is growing rapidly. And we examined this, again, in a study that we published in Open Heart, looking from 2004 to 2011. And you can see that there was an inflection around 2008. This is in patients 65 and older. We're seeing it across, of course, younger patients too, but there's no evidence that this is slowing down. This is raising a lot of questions about the indications, who benefits. Of course, the costs of care are very high. The complications of the LVAD are far too common. We are facing very difficult decisions. This gets to the network and systems issues. Where should they be evaluated? Should there be standard criteria? Should they be occurring within regional sites? Who can be making these decisions? And how are they best handled? Within a healthcare system that's fully funded by the government, this is something which must entail public dialogue as people decide what the best course is. And I wanted to just say one more thing. It's also raising questions about end of life. Both the ICDs and the LVADs. As people get sicker, as they get comorbidities, as Alzheimer, dementia, other problems occur, cancer, how do we deal with these devices? For the ICDs in our country, there's a lot of discussion about should at the time of implantation there be discussions about end of life, when they might be turned off, how they might be used. Even pacemakers, people are talking about these issues. And recognizing that as we put more and more device in older and older people, that we need to include this in part of our discussions as cardiologists so that there's full understanding at the outset about what some of the difficult ethical decisions might be ultimately. This is a slide from an abstract that was presented at the HA that's just showing also palliative care and hospice care at discharge for patients admitted with heart failure is increasing. There's increasing awareness of the importance for us, not just to try to do the great save, to make sure we've rescued someone from a terrible shock, but that we're also on the other side working with families and patients to understand what their goals are, where they are in their disease, and what the proper course is with them, so that we're sensitive on both sides, where we need to be very aggressive with our therapies, where we need to pull back and help them achieve the goals that they've set for themselves, given their condition. So finally, I want to raise one more thing. There's this issue of heart failure. We can all see the classic picture of all of the signs and symptoms. But I'm going to ask you a question. What is heart failure exactly? Because really, there's no lab test. BNP, no, not really. There's no lab test that makes the definitive diagnosis. There's nothing worse for me than in the echo lab, somebody sends down a request trying to diagnose heart failure. You can't diagnose heart failure in the echo lab. You can gain information which can push you in one direction or the other, but it's a clinical syndrome. It's a diagnosis of a syndrome. And we have to admit that there are a very few number of patients who are so clear, everyone will agree, but there are many more for whom there's a lot of disagreement. The Framingham criteria rarely applied and rarely helpful. Our taxonomy, taking from the talk last night of preserved systolic function versus depressed systolic function, is so simplistic. It doesn't truly capture it, and the ejection fraction is not the diagnosis of heart failure. When we looked at what's actually happening in the United States, we discovered something quite disturbing. Published this study in PLOS 1. Acute decompensated heart failure is routinely treated as a cardiopulmonary syndrome. What we found is that people who are labeled as heart failure are commonly treated also for COPD, asthma, and pneumonia. So we are finding that many people get a triple therapy initiated on admission when they're coming in with a primary shortness of breath. Even the x-ray may be equivocal. Is it an infiltrate? Is it redistribution? Does it represent congestion? Of course, people on the physical examination are losing their skills. We're unable to make the clear and distinct distinction, so we decide to treat them with everything. And this is a question then, how many types of heart failures? How do we classify? Who benefits for what therapy? What we are doing right now in practice is giving most people everything. And so in our paper we saw there's about a third of patients who are only treated with heart failure treatments. And then we saw heart failure plus bronchodilators, heart failure plus antibiotics, heart failure plus corticosteroids, heart failure plus antibiotics. In fact, we saw many people who were, in another paper we wrote about, who were getting both fluid boluses and diuretics at the same time. We couldn't even figure out what they were treating exactly in the initial treatment. Not that they had been over-diuresed and now were being treated with fluid bolus, but in the initial treatment. There's a lot of confusion. I recommend you to the paper. This is a complicated figure. But I'll tell you in the end, this dark area, so this represents people who start with heart failure only. 6% get sent home very early. 25% have their heart failure treatments, the diuretics, discontinued. And 69% have it continued throughout the entire hospitalization. All these people are labeled with heart failure. The people who are started with heart failure plus bronchodilators, or antibiotics plus minus bronchodilators, or steroids plus minus bronchodilators, the dark area are the people who are continued with this therapy throughout the entire hospitalization. So you have a lot of people who are given triple therapy for the entire hospitalization, 5 or 6 days, and sent home. And then they're labeled with heart failure. I tell you, this is a much more difficult issue than we've given it credit for. Older patient comes in with a cardiopulmonary syndrome. Somebody labels them with heart failure, their echo's obtained, it has a normal squeeze. We say heart failure with preserved systolic function, and maybe pneumonia, and maybe COPD. I think a lot of people being labeled with heart failure with preserved systolic function are a group of people we don't know what they have. And when we say 50% of heart failure, or 60% in the elderly, is with preserved systolic function, it represents a group with a cardiopulmonary syndrome for which most of those patients, there's substantial uncertainty, and for which, at least in the United States, most of those patients are being treated with more than one therapy, sometimes triple therapy. And so it's going to be up to us to try to clarify this situation if we're to be able to give more precise diagnosis and to be confident in the treatments that we're giving and understanding what they're providing. These patients go home, now they're labeled with heart failure. Maybe they do, maybe they don't. It's hard to know. So this represents the final thing to do. So my conclusions. Heart failure, whatever it is, it's decreasing and mortality is decreasing. But we're seeing increasing comorbidity, increasing LVADs, and a troublesome taxonomy, difficult in classifying it. Outpatient in particular, but also inpatient. We would benefit from comprehensive ongoing registry with longitudinal study that helps us better classify these patients, better characterize the phenotype, better estimate the risk, better evaluate the response, and we need more information about outpatients in particular. Thank you.
Thank you, Harlan. We have some time for questions and discussion. Is there any question from the audience? Yep.
See if anyone I'm going to see if anyone wrote anything on Twitter.
Okay, thank you very much for your lecture. It's a question for Professor Harjola. It's about its reality that the 30 days mortality or in-hospital mortality of STEMI, for example, acute myocardial infarction, has decreased in the last few years or the last decades. But there's a special scenario, which is the cardiogenic shock, which the mortality remains nearly invariable, nearly of about 40%, more or less. And you see all those drugs in the last trials, or in the several trials, have done demonstrate his beneficial effect. I asked about another approach. What do you think about it? For example, a mechanical approach of this, not with a balloon of counterpulsation balloon, but could be with a device of a system device, for example. And what do you think about it, please?
Yeah, this is a very good question. So about how to treat cardiogenic shock patients. I didn't have time to show, for example, our risk score. We did a European multicenter study on cardiogenic shock and published a risk score in that paper last year in European Journal of Heart Failure. And one aim of the risk score would be to detect the patient at the highest risk early enough, because we have a whole range of patients, even in cardiogenic shock, those who have very good prognosis, who do not have several criteria of poor prognosis. But for example, high lactates, renal failure, confusion, acute myocardial infarction, old age. So these all add up to higher level of risk. And I think these patients who benefit from mechanical circulatory support should be detected before the first 24 hours. If you delay longer, you will get more and more severe organ failure, and then the vicious cycle downwards. We treat patients quite a lot also, not only with dobutamine, norepinephrine, we also use levosimendan together with norepinephrine and try to find the optimal ways, but we still do not know what is the best approach for the patients.
So I would like to ask two questions to each one of you, but I would like to actually switch your talk. So actually you also mentioned it, Harlan, but I was wondering whether this difficulty in phenotyping and subclassifying this number of different syndromes that Veli-Pekka mentioned, that is probably one of the biggest challenges in terms of finding an effective treatment, is not the perfect group for precision medicine that you talked about yesterday. Whether that would be an option for an approach to solve this problem. And for you, Veli-Pekka, I would turn to Harlan's question whether actually these challenges that we have in this, let's say, lack of specialization in the emergency departments would be solved having networks for acute heart failure, or if that is really realistic, because this is such a huge problem. Maybe for cardiogenic shock we should have networks, referral networks within our systems.
Yes, I think this very good thing of thinking about networking and to finding out real life data and find data from registries, because we know that performing prospective randomized trials in, for example, cardiogenic shock would be very challenging, and all the trials have something around 40-50 patients all together, and then we have the largest studies like IABP Shock 2, which has around 600 patients, but all the rest are rather small. And to continue from this networking issue regarding the cardiopulmonary syndrome treatment, so I really share your idea. In real life, doctors really give furosemide, they give cefuroxime, they give bronchodilators. But do you know, or you have to know, what is the prognostic role of this kind of shotgun approach compared with more aimed?
Well, in our study, we saw that it was associated with outcome, obviously more associated with worse prognosis. The question is, of course, with selection, I think that the sicker patients, people are more likely to want to give more. In the database we had information about treatments. It was all ages, by the way. This was a database from about 600 hospitals in the United States who provided, we knew about all the treatments, but we didn't know the blood pressure, the clinical situation of the patients coming in. So we weren't comfortable being able to say, is it the treatments or are they a marker of severity? But I think one of our problems is that, by the way, so just to build on what the question to me was, that this is ideal for precision medicine. It's just not ideal for precision medicine based on genomics. It's based on precision medicine based on clinical presentation, on context, on a whole range of other factors about patients. But we have to decide what's the minimum data set, what's the minimum information we need. Plus, we need to get away from the illusion of certainty. So the idea of saying, well, we have to call them something, so let's call them a patient with heart failure, labeling him that, as opposed to labeling them with the uncertainty of a cardiopulmonary syndrome that that had features of a couple of different conditions. We have guidelines that are purely about heart failure, but they have virtually no information about how to care for the older individual with polypharmacy in multiple comorbid conditions. And in part that's because we've generated so little evidence about maybe the triple therapy is actually a good thing to do. Do that for 48 hours and then decide, because if you miss a pneumonia or you're missing COPD, they're not going to get better, but instead of, maybe it's no harm. Or maybe it actually is harmful. And I've seen situations where people are giving beta blockers and beta agonists to people with certain conditions. And it all seems like it's counter to what may be in the best interest of the patients. But it's time for us to embrace the complexity of our patients and seek studies that help us understand how best to care for people who do not have solely one problem. And that is not solely one active problem. It's one thing to say they have 5 problems, but they're quiet. This is just the one that's loud. We need to address it. But many of our patients, particularly in acute settings, one thing triggers another that triggers another, and they've got 2 or 3 active problems. And we've got to be able to figure out how do we juggle that, because increasingly that is the common thing. When I look to the doctors of the future, they're not going to be treating the conditions of the past, where we were fortunate enough often to have young people come in with a singular problem that we could treat in a very narrow fashion. Doctors of the future are juggling many more different conditions in complex patients. We need to generate the evidence to keep up with that.
Have a question? I have one for you, Veli-Pekka. Okay. That's regarding what's your practice and your recommendation regarding the optimal timing of coronary angiography and revascularization in a patient with suspected acute coronary syndrome presenting with acute pulmonary edema? Because guidelines recommend immediate angiography in these patients, which is possibly good for many of them, but also makes them in danger of probably perhaps worse pulmonary function, greater need of intubation, greater risk of renal descompensation. So what do you do in this subset?
So I think, of course, for ST elevation, you do the primary PCI, but for non-ST elevation, so there most likely is time for stabilization of the patient to start with. If the patient has high blood pressures and pulmonary edema, so you start with nitrates, you start with CPAP management, and you have time to stabilize the patients before going then to cath lab. So I think this is our approach.
Is there any more questions? So I would like to ask you both a question about this terribly frustrating situation of the systematic failure of randomized trials in acute heart failure, finding no single treatment being effective in heart failure. My question is, and I think you both put the same thing, I mean, the problem is there's no average, as you said yesterday, or just a single syndrome. But still, I think there's still this trend to find this silver bullet that will kill acute heart failure, which I think is hopeless. But my question is, how should we, if there's any clear solution of how to handle these randomized trials, should we run bigger randomized trials and then pay more attention to subgroup analysis? Should we stop doing randomized trials until we understand better the disease? Should we just try to phenotype better and just focus on a subgroup of patients? What do you think would be a solution for improving the efficacy of randomized trials in acute heart failure?
So I think we have faced different, let's say, different scenarios in making the randomized trials. When the trials with levosimendan were performed, there were almost no exclusion criteria. The patient could have a blood pressure of 86 millimeters of mercury with acute coronary syndromes, whatever dysrhythmia. So a wide range of scenarios in the same clinical trial. Even the inclusion time was not limited. So this was a whole, I would say, a mess of patients, and very difficult to find differences between any therapies. Then on the other hand, the current trials, they have so strict inclusion criteria and exclusion criteria that everybody knows that it's very hard to find any patients. Even though you have 100 patients in a clinic, you find one to the randomized trial. So this makes it very difficult to generalize the results from those trials. And for example, from the Spanish EAHFE registry, there was a nice comparison of real-life patients and relapsed AHF patients, which didn't match quite at all. And then we do not know what is the optimal therapy of acute heart failure. So if we start some kind of study drug, so then we adjust the background therapies, and again you may lose the effect. So maybe we have to use the registries and networking to get more and more data.
Well, I think this is a phenotype problem in the sense that when you throw together a very heterogeneous group of individuals, you likely have some people who respond and some who don't respond, and maybe some who have negative response, and your average ends up making it very difficult to figure out who might best benefit from the treatment. But the one thing I would say about the restrictions are, I think it's not the restrictions, it's just they're the wrong restrictions. In the sense that everyone wants, I don't know what the best word to use, sort of the purest heart failure population for the trials to prove the concept that it can improve. But it's demonstrating to us that these are very rare. You can't find them. If actually you want a very pure group of patients with diastolic dysfunction, heart failure with preserved systolic function, I once asked someone who put together a study of 100, I said, how many did you have to screen? They said about 4,000. And it's telling us something. We should be focusing on studying the most prevalent groups, phenotyping them within so that there's not so much heterogeneity, but recognizing that the complexity is part of the condition now. That giving us knowledge about a very narrow group of pure heart failure who've got no other problems, no other competing risks, is going to only provide us insight into a very rare group of patients. And so we've got to figure out how can we aim for where the most exist. We still have millions and millions of patients across countries who are suffering from this problem. It's just that the vast majority of them are complex, and we have to figure out how to study them. If in the end complex patients are not amenable to simple interventions, then that teaches us something. But I think even within that group, we're going to have to go to subgroups of somewhat similar characteristics. But there are many people with similar characteristics. It's just they're complex. And most trialists have wanted to steer away from complex patients, thinking it's too hard.
Yeah. Well, thank you very much. I think it was a really exciting session. Obviously, acute heart failure is one of the huge challenges in acute cardiovascular care, and we need, as a thing we learned on this session, much more focused research to move on this field. So thank you very much, Harlan and Veli-Pekka.